Namaste Bitya, Amisha Kushwa Bitya. A very good morning to you all. Myself, JV and Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine and Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. In this series, we are discussing about the locomotor system, the diseases of the locomotor system. Till now, we have discussed about the various diseases like osteoarthritis, we have discussed about rheumatoid arthritis, ankylosing spondylitis, reactive arthritis, and psoriatic arthritis. In today's lecture, we are going to discuss about yet another important disease, that is gout. Gout is a very common disease that we see in our day-to-day population. This is also an important question from the examination point of view, because you get a full question on of 20 marks on gout. So let's discuss about gout. But before starting with the gout, let me remind you that you have to go through the topics, all these topics that we have covered from the book, and then you have to revise each and everything, because these are the video lectures and you have to refer your books as well for complete knowledge. So let's start with the gout. What is gout? What are the etiopathogenesis, the clinical features, investigations, and management of gout? So gout is basically a disease that is associated with the deposition of crystals of uric acid with the swollen and inflamed joint, and because of the deposition of uric acid crystals in the joint. Now, what is gout? Gout is a form of inflammatory arthritis. So this is basically an inflammatory arthritis with high levels of uric acid in the blood. So in gout, you are getting high levels of uric acid, and this is a form of inflammatory arthritis with a high level of uric acid in the blood. The acid forms needle-like crystals in the joint. So there are various kind of needle-like crystals that you see in a joint, and it is inflammatory arthritis with high level of uric acid. In gout, it causes sudden, severe episodes of pain and tenderness with redness, warmth, and swelling. So there is sudden, severe episode of pain. So whenever a patient of gout is coming to us, we see sudden and severe pain and tenderness and redness with warmth and swelling of the joint. There is also a condition of hyperuricemia, in which there is increased uric acid content in the blood. The plasma and extracellular fluid becomes supersaturated with uric acid. So due to uric acid, the plasma and extracellular fluid is becoming supersaturated. The normal uric acid, the plasma uric acid, is 2.5 to 6 mg per dl in women and 3.4 to 7 mg per dl in men. So what is gout? Gout is an inflammatory form of inflammatory arthritis with a high levels of uric acid in the blood. The uric acid forms needle-like crystals in the joint, and there is sudden severe episodes of pain and tenderness with redness, warmth, and swelling. There is hyperuricemia with plasma and extracellular fluid that is getting supersaturated with uric acid. The normal plasma uric acid is 2.5 to 6 mg per dl in women and 3.4 to 7 mg per dl in men. Now, what is hyperuricemic cascade? I have shown you with the flowchart how the uric acid is formed in the blood. So urate is coming from three different sources. We have dietary purines. Right? So we have dietary purines, the tissue nucleic acid, and endogenous purine synthesis. All these three mechanisms results in the formation of urates. There is overproduction of urate or under excretion of the urate lead to the increased concentration of urates in the blood, that is known as hyperuricemia. This hyperuricemia can be silent tissue deposition, or it can lead to gout. So there can be silent tissue deposition, there can be gout, there can be renal manifestations, and it can be associated with cardiovascular events and mortality. So in the hyperuricemic cascade, we have dietary purines, we have tissue nucleic acid, we have endogenous purine synthesis with urate, overproduction of urate or under excretion of urate result in the hyperuricemia. This causes silent tissue deposition with gout, renal manifestations, and associated cardiovascular events and mortality. Now, gout is basically a metabolic disorder of purine metabolism that is characterized by recurrent attacks. There are recurrent attacks of acute arthritis. We have chronic deforming arthropathies. There is formation of the profile and systemic complication like renal failure. So in gout, it is basically a metabolic disorder of purine metabolism. All right, so there is purine metabolism that is characterized by recurrent attack of acute arthritis. We have chronic deforming arthropathies. There is formation of tophi and a systemic complication like renal failure. So this you have to remember, like acute arthritis, there is chronic deforming arthropathies, there is formation of tophi. Tophi formation is typical in gout and systemic complications like renal failure. The incidence, the gout affects the middle-aged to elderly men and postmenopausal women. So gout, what is the population that is getting affected by gout? It is affecting middle-aged to elderly men and postmenopausal women. The male to female ratio is 7:1 to 9:1, and only 5% of hyperuricemic patients develop gout. So out of the 100 patients we are getting of hyperuricemia, only 5% of the patients are developing gout. So it affects middle-aged to elderly men and postmenopausal women. The male to female ratio is 7:1 to 9:1, and it occurs in around 5% of hyperuricemic patients that develop gout. Most women with gouty arthritis are postmenopausal and elderly. So most of the women with gouty arthritis are usually postmenopausal and elderly. They have osteoarthritis and arterial hypertension that causes mild renal insufficiency. So there is mild renal insufficiency and usually are receiving diuretics. So most of the women who are developing gout are postmenopausal and elderly. They have osteoarthritis and arterial hypertension that causes mild renal insufficiencies and usually are received diuretics. Now, what is the pathogenesis? Pathogenesis for development of gout. The pathogenesis consists of the uric acid, which is the end product of purine nucleotide degeneration. So we have purine nucleotide degeneration that is resulting in the formation of uric acid, and its production is closely linked to the pathway of purine metabolism. So there is pathway of purine metabolism with intracellular concentration of 5-phosphoribosyl 1-pyrophosphate, that is 5-pyrophosphoryl 1-pyrophosphate PRPP. The uric acid is excreted primarily in the kidneys through glomerular infiltration, tubular secretions, and reabsorption. So the uric acid that is excreted, it is primarily by the kidney through the glomerular filtration, tubular secretion, and reabsorption. We have hyperuricemia that arises with the overproduction or reduced excretion of the uric acid or combination of these two things. So uric acid that is excreted primarily by the kidneys through the glomerular filtration, there is tubular secretion, and reabsorption. Hyperuricemia that it arises with the overproduction or reduced excretion of the uric acid or the combination of these two. There is arthritis. Arthritis that is caused due to deposition of monosodium urate crystals or MSU crystals in the synovium. So the arthritis in case of gout occurs because of the deposition of monosodium urate crystals or the MSU crystals in the synovium. There is polymorphonuclear leukocytes that ingest crystals and release lysosomal enzymes, which causes inflammation. So there is arthritis, which is caused due to deposition of monosodium urate crystals in the synovium. There are polymorphonuclear leukocytes that ingest crystals and release lysosomal enzymes, which causes inflammation. There is acute arthritis, where the crystals are demonstrable in the synovium and articular cartilage. There is chronic arthritis with erosion of the articular cartilage. There is proliferation of synovial membrane and pennus formation. That is secondary osteoarthritis changes occurs. So arthritis is caused due to deposition of monosodium urate crystals in the synovium. There are polymorphonuclear leukocytes that ingest crystals and release lysosomal enzymes, which causes inflammation. There is acute arthritis in which the crystals are demonstrable in the synovium and articular cartilage. The chronic arthritis, erosion of articular cartilage, proliferation of the synovial membrane, and pennus formation takes place. That is, secondary osteoarthritis changes occurs. The tophi are nodular urate deposits in and around the joints in the articular cartilage. I have shown in the PPT, I have also shown the changes of the in the electron microscope, how the monosodium urate crystals are seen. Now, histologically, when we are looking in the microscope, histologically, the monosodium urate crystals are surrounded by mononuclear cell infiltration. So, the monosodium urate crystals are surrounded by monosodium cell infiltration and foreign body giant cells, which leads to three things. One, osteoarthritic changes. Second, ankylosis of the joint, and the third is tissue destruction. So the monosodium urate crystals are surrounded by mononuclear cell infiltration and foreign body giant cells, which leads to number one, osteoarthritic changes, ankylosis of the joint, tissue destruction, and long-standing cases develops multiple renal calculi with pyelonephritis and atherosclerosis. Now, what are the clinical features of gout? Whenever a patient of gout is coming to us, what are the various clinical features that we are going to see? The gout passes through three clinical stages. Number one, we have asymptomatic hyperuricemia. Number two, we have acute gouty arthritis, and the third is chronic tophaceous gout. So gout passes through three clinical features, which includes asymptomatic hyperuricemia, we have acute gouty arthritis, and chronic tophaceous gout. What are the three features? Asymptomatic hyperuricemia, in which there is only increased level of uric acid without any clinical feature. Second is acute gouty arthritis, and the third is chronic tophaceous gout. Now, what happens in acute arthritis? Acute arthritis, it is only one joint that is affected initially. In acute arthritis, only one joint is affected initially, but polyarticular acute gout in subsequent episodes are seen. The first joint, it is metatarsophalangeal joint of the first toe that is involved. So greater toe is involved. There are inflamed hyperdents or Bouchard's nodes that could be seen as the first manifestation of gouty arthritis. It begins at night with a dramatic pain, swelling, warmth, and tenderness. There are attacks that will generally subside spontaneously after 3 to 10 days. There are recurrent episodes of intervals of varying lengths with no symptoms between the attacks. So in case of acute arthritis, only one joint is initially affected, but polyarticular acute gout in subsequent episodes. The first joint consists of metatarsophalangeal joint of the first toe that is involved with inflamed hyperdents or Bouchard's node. That may be the first manifestation of gouty arthritis. It begins at night with dramatic pain, swelling, warmth, and tenderness. The attack will generally subside spontaneously after 3 to 10 days. There are recurrent episodes in the interval of varying length with no symptom between the attack. Next important feature of gout is podagra. What is podagra? Podagra is basically painful affection of the foot that is occurring as a result of metatarsophalangeal arthritis. So what is podagra? It is basically the painful affection of the foot occurring as a result of metatarsophalangeal arthritis. Later, other tarsal joints, ankles, and knees are also getting involved. These are associated with fever and constitutional disturbances. So what is podagra? Podagra is basically painful affection of the foot that is occurring as a result of metatarsophalangeal arthritis. Later, other joints, tarsal joints, ankles, and knees are also getting affected. These are associated with fever and other constitutional disturbances. Now, what are the precipitating factors for gout? What are the various factors which are leading to the development or precipitation of gout, or leading to the development of symptoms of gout? Number one, we have dietary excesses. So dietary excess, if a patient is taking excess of red meat, liver, pancreas, testes, peas, etc., this will lead to the development of gout. So what are the dietary excesses, which include red meat, liver, pancreas, testes, peas, etc.? Trauma, any kind of injury will lead to the development of gout. Surgery of different kind with excessive ethanol ingestion. So there is trauma, there is surgery, excessive ethanol ingestion. If a patient is taking a lot of alcohol. Hyperuricemic therapy, any therapy which leads to the increase in the content of uric acid in the blood, and serious medical illness such as myocardial infarction and stroke. So precipitating factors include the dietary excess of red meat, liver, pancreas, testes, and peas, etc. Trauma, surgery, excessive ethanol ingestion, hyperuricemic therapies, and serious medical illness such as myocardial infarction and stroke. Now we come to the chronic arthritis. In the chronic arthritis, there is recurrent attack of non-symmetrical synovitis. So what happens in chronic arthritis? We have recurrent attack of presence with non-symmetrical synovitis. It manifests only as periarticular tophaceous deposits in absence of synovitis. The tophi are soft and small, but later becomes hard and may reach up to 7 cm in diameter. The tophi may ulcerate, discharging chalky material, and the common sites for tophi are around olecranon process, ankles, tendon Achilles, helix of the ear, and other joints. So in chronic arthritis, there is recurrent attack represents with non-symmetrical synovitis. They manifest only as periarticular tophaceous deposits and absence of synovitis. The tophi are soft and small, but later becomes hard and may reach up to 7 cm in diameter. The tophi may ulcerate, discharging chalky material, and the common site for tophi are around olecranon process, ankles, tender Achilles, and helix of the ear and other joints. Now, what are the complications that you are going to see in case of gout? The complications includes renal damage by obstruction of renal tubules by urate crystals, urate deposition in the renal parenchyma, leading to the renal failure, the major cause of death in gout. There are various cardiovascular system illnesses like hypertension and ischemic heart disease. Gout is associated with insulin resistance. So various complications which include renal damage by obstruction of renal tubules by urate crystals, urate deposition in the renal parenchyma, leading to renal failure and major cause of death in the gout. The cardiovascular systems includes hypertension and ischemic heart diseases. The gout is associated with insulin resistance. Now, how to diagnose a case of gout? Whenever a patient of gout is coming to us, how will you diagnose the case? Diagnosis is done by synovial fluid analysis. Means in gout, you are going for synovial fluid analysis with the demonstration of needle-shaped crystals or the MSU crystals. There is serum uric acid with the elevation, but normal levels do not rule out the gout. The urine uric acid level, where there is excretion of greater than 800 mg per day in absence of drugs, suggests overproduction. The screening for risk factors, which includes urine analysis, serum creatinine, liver function test, glucose and lipids, and complete blood counts. If overproduction is suspected, the measurement of erythrocyte hypoxanthine, guanosine, phosphoryl transferase or HGPRT and PRPP levels are seen. Joint X-ray is done to demonstrate the cystic changes that occurs in the erosion with sclerotic margination in advanced chronic arthritis. If renal stone is suspected, abdominal plate examination is done with the stone often radiolucent, possibly intravenous pyelopathy. And then chemical analysis of the renal stone takes place. What are the differential diagnoses? What are the various conditions which resembles gout? Differential diagnosis consists of septic arthritis. We have reactive arthritis, calcium pyrophosphate dihydrate CPPD deposition disease, and rheumatoid arthritis. So in differential diagnosis, we have septic arthritis, we have reactive arthritis, we have calcium pyrophosphate dihydrate CPPD deposition disease, and rheumatoid arthritis. The treatment consists of acute stage consisting of symptomatic relief only, since attacks are self-limiting and will resolve spontaneously. Analgesics, non-steroid anti-inflammatory drugs, intra-articular glucocorticoids, systemic glucocorticoids, and uric acid lowering agents. I will again repeat the treatment. In the acute stage, we have to give symptomatic relief only, since attacks are self-limiting and resolve spontaneously. There is analgesia with non-steroid anti-inflammatory drugs, administration of colchicine, intra-articular glucocorticoids, and systemic glucocorticoids with uric acid lowering agents. So this was all about gout. In the next lecture, we are going to discuss about calcium pyrophosphate dihydrate deposition disease or pseudo-gout. So I hope the gout is clear to you. If you have any query, please go through the book and try to resolve any of the query. So this session is powered by Digital Version 2.0, JAYOTI VIDYAPEETH Women's University. I hope the session is clear to you. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. And gout is a big topic, and just go through it once again and try to figure out all the things. Let me have a quick review of gout once again in a very fast manner. What is gout? Gout is basically a form of inflammatory arthritis with a high level of uric acid in the blood. The uric acid forms needle-like crystals in the joints, and it has a sudden severe episodes of pain, tenderness, redness, warmth, and swelling. There is hyperuricemia with increased uric acid level in the plasma. Gout is characterized by recurrent attack of acute arthritis, chronic deforming arthropathies, formation of tophi, and systemic complications like renal failure. It occurs in middle-aged to elderly men and postmenopausal women, with male to female ratio is 7:1 to 9:1. More common in men. Only around 5% of the hyperuricemic patient develop gout. Most of the women with gouty arthritis are postmenopausal and elderly and have osteoarthritis and arthritis, hypertension that causes mild renal insufficiency and usually are receiving diuretics. The pathogenesis consists of uric acid, that is the end product of purine nucleotide degeneration. Its production is closely linked with the pathways of purine metabolism with intra-articular concentration of 5 phosphoribolides, 1 pyrophosphate. Uric acid is excreted primarily in the kidney through glomerular filtration, tubular secretion, and reabsorption. So there is glomerular filtration, tubular secretion, and reabsorption, with hyperuricemia arising from overproduction or reduced excretion of the uric acid, or the combination of two. There is arthritis that is caused due to deposition of MSU, that is monosodium urate crystal, in the synovium. There is polymorphonuclear leukocytosis, which ingest crystals and release lysosomal enzymes, which causes inflammation. There is acute arthritis, where the crystals are demonstrable in the synovium and articular cartilage. There is chronic arthritis with erosion of articular cartilage, proliferation of synovial membrane, and pannus formation. That is secondary osteoarthritic changes occurs. Tophi are nodular urate deposits in and around the joints and articular cartilage. Histologically, monosodium urate crystals are surrounded by mononuclear cell infiltration and foreign body giant cells, which leads to osteoarthritic changes, ankylosis of the joint, and tissue destruction. Gout, clinical features of the gout, it passes through three clinical phases: asymptomatic hyperuricemia, acute gouty arthritis, and chronic diffuse gout. Asymptomatic hyperuricemia, acute gouty arthritis, and chronic diffuse gout. In acute arthritis, there is only one joint involved, but polyarticular arthritis gout is subsequent episode. First joint that is involved is the metatarsophalangeal joint of the great toe. Inflamed hypertension boucher nodes may be seen in first manifestation of the gouty arthritis. It begins at night with dramatic pain, swelling, and warmth and tenderness. Attack will generally subside spontaneous after 3 to 10 days. There is recurrent episodes of interval of varying length with no symptom between the attack. Next, we have podagra. Podagra is painful affection of the foot occurring as a result of metatarsophalangeal arthritis. Later, other joints like tarsal joints, ankles, and knees are also involved. There is association of fever and other constitutional disturbances. Precipitating factors, which includes dietary excess of red meat, liver, pancreas, testes, peas, etc. There is trauma, surgery, excessive ethanol ingestion, hyperuricemic therapy, and serious medical illness such as myocardial infarction and stroke. In the chronic arthritis, there is a recurrent attack of non-symmetrical synovitis. It will manifest as polyarticular capricious deposit in absence of synovitis. The tophi are soft and small, but later becomes hard and may reach up to 7 cm diameter. The tophi may ulcerate, discharging chalky material. The common sites of tophi are around olecranon process, ankles, tendo Achilles, helix of ear, and other joints. The complication includes renal damage, cardiovascular system, which includes hypertension, ischemic heart disease, and it is associated with insulin resistance. The diagnosis is done by synovial fluid analysis with the presence of MSU crystals, serum uric acid level, urine uric acid excretion greater than 800 mg per day, screening for various risk factors like urine analysis, serum creatinine, liver function test, glucose and lipids, and complete blood count. If there is overproduction that is suspected, measurement of erythrocytes, hypoxin, guanosine, phosphorylated transferase, and PRPP levels. Joint X-rays may demonstrate cystic changes with erosion, sclerotic margins, and advanced chronic arthritis. If the renal stones are suspected, there is abdominal flat plate abdominal scan with chemical analysis of renal stone. Differential diagnosis of gout involves septic arthritis, reactive arthritis, calcium pyrophosphate, deposition disease, and rheumatoid arthritis. In the treatment of acute stage, there is symptomatic relief only since the attacks are self-limiting and will resolve spontaneously. Analgesics are given, non-steroidal anti-inflammatory drugs, colchicine, intra-articular glucocorticoids, systemic glucocorticoids, and uric acid lower agents are given. So this was all about gout. In the next lecture, we are going to discuss about CPPD, deposition disease, or the pseudo-gout. So this session is powered by digital version 2.0 JAYOTI VIDYAPEETH Women's University. I hope you have understood the session properly. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much.